Let's look at the gastroesophageal junction. When the lower esophageal sphincter weakens, it creates a mechanical failure. Stomach acid escapes upward into the esophagus, causing reflux. To fix this, surgeons don't implant synthetic parts. Instead, they use the patient's own stomach tissue to engineer a replacement valve. The procedure usually begins laparoscopically. Surgeons insert 5 cannulae into the upper abdomen, above the umbilicus, and separate the lower esophagus from the diaphragmatic hiatus to expose the workspace. Before they can build the new valve, they divide the short gastric vessels. This physical release frees up the top section of the stomach, the fundus, so it can be manipulated. This model demonstrates the classic Nissen Fundoplication. The fundus is drawn behind the esophagus, pulled around to the front, and sutured to create a complete 360-degree collar. In a toupee procedure transition, the fundus is sutured only laterally, leaving the anterior aspect exposed. Both of these wraps require a specific baseline condition. The esophagus must have enough natural length and slack so that the newly constructed valve sits comfortably within the abdomen without tension. When acid reflux goes untreated for years, the damage moves past gross mechanics and begins altering the tissue itself. In this microscopic cross-section, flat squamous cells lining the lower esophagus are eroded by acid. As a defense, the body replaces them with taller columnar cells. Zooming out, this abnormal lining migrates beyond the stomach junction, sometimes reaching the aortic arch. This cellular shift is known as Barrett's esophagus, and it carries specific clinical risks. The columnar tissue can undergo dysplasia, elevating the threat of adenocarcinoma. Because of this, surgeons must take multiple mucosal biopsies to rule out malignancy before performing any anti-reflux surgery. The body successfully defends against immediate acid erosion, but it makes a dangerous biological trade, creating an environment that carries a long-term risk of cancer. The pathology of Barrett's often involves chronic inflammation and ulceration. As this inflamed tissue scars at the junction of the squamous and columnar cells, it forms thick, rigid strictures. This vector diagram illustrates the main biomechanical consequence of that scarring. A stricture doesn't merely narrow the passageway, it contracts vertically. The entire esophageal tube is physically shortened and pulled tautly upward into the chest. The required medical baseline to combat this involves aggressive therapy and repeated physical dilatations. Physicians carefully widen the passage until a number 40 French bougie can successfully clear the stricture, significantly reducing edema and spasm. Pause for a second and consider the geometry here. If a severe stricture has contracted the esophagus so much that it can no longer reach down into the abdomen, how can a surgeon possibly use the stomach to wrap around it? That structural shortening breaks the primary rule for a standard Nissen repair, forcing the surgeon to artificially lengthen the operative field. If the natural esophagus is too short, the surgical solution is the Collis Gastroplasty. The surgeon sacrifices the upper portion of the stomach to build a new esophageal extension. In this graphic, we see a rigid number 40 French bougie push down through the shortened esophagus, extending straight into the upper stomach cavity. This tool serves as an internal sizing mold. The surgeon makes a vertical, longitudinal incision straight down the upper stomach tissue, running exactly parallel to that internal bougie. The tissue on the lesser curvature side of the cut is sutured tightly around the mold. This transforms a section of the stomach into an elongated neo-esophagus, extending the tube straight down into the abdomen. Now that adequate length is restored, the remaining outer flap of the divided stomach, the redundant fundus, is wrapped completely around this newly constructed tube to form a secure anti-reflux valve. When chronic inflammation destroys natural anatomy, precise surgical geometry allows us to repurpose existing tissue and restore mechanical function. This 3-panel infographic maps out the progression. In Panel 1, normal anatomy with adequate esophageal length easily accommodates a standard 360-degree Nissen wrap. When unchecked reflux triggers cellular changes, the body develops Barrett's esophagus, and the subsequent strictures physically shorten the operative field. The operative rules follow the anatomy. Utilize a standard wrap for a normal length tube. Always perform biopsies on Barrett's tissue first, and deploy a Collis Gastroplasty to reconstruct the tube when strictures compromise your length.
Achalasia is a disorder in which the lower esophageal sphincter fails to relax, preventing food from entering the stomach. As food accumulates, the esophagus gradually dilates, causing dysphagia, regurgitation, chest discomfort, and weight loss. The definitive surgical treatment is a laparoscopic Heller's myotomy, usually combined with an anterior door fundoplication. After induction of general anesthesia, the patient is positioned in a reverse Trendelenburg position. Small laparoscopic ports are inserted into the upper abdomen. The left lobe of the liver is gently elevated, exposing the esophageal hiatus and the gastroesophageal junction where the operation begins. The phrenoesophageal membrane is carefully divided to enter the hiatus. The lower esophagus is gently mobilized within the mediastinum while preserving both the anterior and posterior vagus nerves. Fibrous attachments surrounding the gastroesophageal junction are released to obtain complete circumferential exposure. Adequate mobilization allows the surgeon to work safely along the distal esophagus and proximal stomach. The muscular layers of the esophagus are now clearly identified. The longitudinal muscle fibers are separated, revealing the underlying circular muscle that forms the abnormally tight lower esophageal sphincter, responsible for the patient's symptoms. The Heller's myotomy now begins. The circular muscle fibers are divided with meticulous precision while the delicate mucosa beneath is preserved intact. The muscle incision is extended proximally along the lower esophagus and continues across the gastroesophageal junction onto the upper stomach. As the muscle separates, the healthy mucosa gently bulges outward, confirming that the obstruction has been completely released. This critical step permanently weakens the non-relaxing lower esophageal sphincter, allowing swallowed food to pass freely into the stomach while avoiding injury to the esophageal lining. Although the obstruction has been relieved, division of the lower esophageal sphincter increases the risk of acid reflux. To prevent this complication, an anterior door fundoplication is performed. The gastric fundus is gently brought over the front of the esophagus, covering the exposed mucosa created by the myotomy. Interrupted sutures secure the fundus to both edges of the divided muscle and the diaphragm. This protective wrap reinforces the repair, shields the delicate mucosa, and reduces postoperative gastroesophageal reflux while preserving the improved passage of food. Although the obstruction has been relieved, division of the lower esophageal sphincter increases the risk of acid reflux. To prevent this complication, an anterior door fundoplication is performed. The gastric fundus is gently brought over the front of the esophagus, covering the exposed mucosa created by the myotomy. Interrupted sutures secure the fundus to both edges of the divided muscle and the diaphragm. This protective wrap reinforces the repair, shields the delicate mucosa, and reduces postoperative gastroesophageal reflux while preserving the improved passage of food. Like every operation, Heller's myotomy carries potential risks, although serious complications are uncommon in experienced hands. The most important intraoperative risk is accidental perforation of the esophageal mucosa during muscle division. If recognized immediately, it can usually be repaired successfully. Bleeding from small blood vessels, injury to the vagus nerves, spleen, or surrounding structures is uncommon but possible. After surgery, some patients experience temporary difficulty swallowing due to swelling. Gastroesophageal reflux may occur if an anti-reflux procedure is not performed. Rare complications include infection, pneumonia, blood clots, or recurrence of symptoms if the myotomy is incomplete or scar tissue develops later. Laparoscopic Heller's myotomy is regarded as one of the most successful operations for achalasia. More than 90% of patients experience significant improvement in swallowing and enjoy long-lasting relief from dysphagia. Most patients begin drinking liquids within hours of surgery and gradually progress to soft foods before returning to a normal diet over the following weeks. Weight gain, improved nutrition, and a better quality of life are common after successful treatment. Regular follow-up helps detect reflux symptoms or rare recurrence of swallowing difficulty. When performed by experienced upper gastrointestinal surgeons, Heller's myotomy with door fundoplication remains the gold standard surgical treatment, providing durable symptom control for many years. Recovery after laparoscopic Heller's myotomy is usually rapid because the procedure is performed using minimally invasive techniques. Most patients are encouraged to sit up and walk on the same day of surgery to reduce the risk of blood clots and improve lung function. Pain is generally mild and controlled with oral analgesics. A contrast swallow study may be performed in some centers to confirm there is no leak before oral intake begins. Patients usually start with clear liquids, progressing to full liquids and soft foods over the following 2 to 4 weeks. Small, frequent meals should be eaten slowly with adequate fluids. Heavy lifting is avoided for several weeks, while normal daily activities are gradually resumed. Patients are advised to report persistent difficulty swallowing, fever, severe chest pain, or vomiting immediately, as these may indicate a complication. Most patients return to work within 2 to 4 weeks and experience a marked improvement in swallowing.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.